Welcome to the deep dive. Today, we're navigating a really critical challenge in orthopedics, understanding shoulder masses. The shoulder joint is, well, it's a marvel of mobility, isn't it? But it's also such a common source of pain and swelling. And when you, as a clinical professional, encounter a patient presenting with a mass in this area, the stakes can be incredibly high. Distinguishing between, say, a rare, life-threatening condition and a benign mimic is just absolutely paramount. So our mission for this deep dive is to arm you with critical insights into the differential diagnosis of these shoulder pathologies. We're going to journey from aggressive bone tumors, each with its unique signature, right through to conditions that, while entirely benign, can put on a surprisingly alarming show, really. Our goal is simple, to sharpen your diagnostic skills and ensure no vital detail gets overlooked in your practice. All right, Professor, let's really dig in then. When we talk about masses in the shoulder, especially those involving the bone, it immediately raises red flags, doesn't it? Can you start by painting that broad picture for us? Historically, how common are primary bone tumors in this region? And why are they such a critical consideration for us today?
Yes, it is a critical area indeed. And you've hit on a crucial point there about rarity versus severity. Primary bone tumors in the shoulder are, statistically speaking, quite rare, especially when you compare them to common things like rotator cuff problems. Early data, for instance, suggested maybe only 1 in 100,000, perhaps 1 in a million people, might be affected by a bone sarcoma in the subacromial region. But, and this is the key point, their potential for fatality makes early, accurate diagnosis an absolute imperative. So, for a young patient complaining of a persistent, dull, aching pain, or maybe presenting with palpable bone thickening that lasts for more than a week, well, prompt imaging is essential. And I mean, especially a simple X-ray to start with. In the past, a really good X-ray combined with a detailed clinical history or perhaps a clear pathological slide could often lead you straight to a diagnosis on its own. That emphasis on simple, good quality imaging still holds true.
That is a striking point about their rarity, yet their severity. It really resonates. So if we delve into the specific types of malignant bone tumors affecting the shoulder, what are those distinct features we really need to look out for? What's the signature that should make us sit up and pay attention?
Excellent question. Let's start with ERA, osteogenic sarcoma. On an X-ray, you'll typically see the original bone shaft still visible within the tumor itself. The tumor usually extends both within the bone's outer layer that's intracortical and beyond it, so extracortical too. Crucially, you need to look for what we call reactive triangles at the tumor's base.
Right.
And sometimes you'll see sunray spicules as well. These are almost a signature, really prompting immediate red flag protocols. Location-wise, they predominantly occur in the metaphysis of the humerus. That's the wider part of the bone shaft near the joint. And critically, they almost never invade the actual articular head or the joint cartilage itself. An interesting clinical point. Pathological fractures are actually surprisingly more common in the humerus with this type, compared to the weight-bearing femur. Historically, the prognosis for osteogenic sarcoma was, well, very poor, an average survival of only about 2 years.
Gosh.
That grim reality truly underscores why early, meticulous imaging today, even for what seems like a simple ache, is so paramount. Because even small delays can be devastating.
Absolutely. And what about Ewing's sarcoma? How does that differ?
Right, Ewing's sarcoma is quite distinct. Unlike osteogenic sarcoma, Ewing's characteristically involves the shaft or the diaphysis of the bone. It can potentially extend right from one end, the epiphysis, to the other. Its X-ray hallmark is often described as onion-like layers of new periosteal bone.
Onion-like layers. Okay.
Exactly. It shows that the growth is centrifugal, pushing outwards and broadening the shaft. You might also see fine, short, radiating spicules. A key diagnostic challenge here, though, is that Ewing's can mimic osteomyelitis.
Ah, bone infection.
Precisely. Because they share features like febrile symptoms and similar appearances on X-ray. However, the pain in Ewing's is often intermittent, especially initially. Historically, its prognosis was considered somewhat more favorable than osteogenic sarcoma.
So if a resident spots those onion-like layers, that's a pretty strong indicator for Ewing's then. But you mentioned osteomyelitis as a look-alike. How easy is it to confuse them?
You're right, those layers are a very strong indicator. But yes, the main mimic is osteomyelitis, particularly in its earlier, perhaps more subtle stages. Both can present with pain, swelling, and that periosteal reaction on the X-ray. So clinical context becomes crucial, doesn't it? A good history, especially regarding fever patterns, response, or lack of response to antibiotics, that helps to differentiate.
Right, makes sense. What's next on the list?
Then we have multiple myeloma, This one has a unique X-ray appearance that's quite striking. The bone looks almost, well, blown up from inside, as if by a series of bubbles.
Wow.
This is due to hyperplasia and overgrowth of the marrow cells. We call an endosteal tumor, meaning it starts from the inner lining of the bone, and it expands quite literally throughout the spongy central part of the bone, the medulla. A defining characteristic is that it is always multiple in origin. Always. Even if it initially appears as a solitary lesion on imaging.
Always multiple, even if it looks single initially. Got it. And finally, metastatic cancer.
Yes, metastatic cancer. This is highly variable in its appearance. It can mimic various primary bone tumors on X-ray, making it a real diagnostic challenge sometimes. But a crucial diagnostic clue is this. Unlike primary sarcomas, which rarely cross the epiphyseal line, metastatic cancer can invade the articular head of the bone right up to the cartilage.
That's a key differentiator.
It really is. In adults, if you see a localized osteolytic tumor that's a destructive lesion in the mid-shaft of the humerus, or involving the upper end, say, from mid-shaft upwards, well, that should raise very strong suspicion of metastatic cancer. Hypernephroma metastases, kidney cancer spreading to bone, in particular, often exhibit an expansile, almost puffed up quality on the X-ray.
That's a vital distinction, that ability of mets to cross the epiphyseal line. But here's where it gets really interesting, isn't it? What if a mass looks aggressive, looks worrying, yet isn't malignant at all? That's where some of these benign conditions come in. Professor, can you talk us through giant cell tumors, especially how they behave atypically in the humeral head? What does that mean for our clinical approach?
Absolutely. This is where diagnosis gets, well, truly fascinating sometimes. Epiphyseal chondromatous giant cell tumors of the upper humerus, quite a mouthful, I know, behave quite atypically in the humeral head compared to how they present in other long bones. You'll typically find them in the region of the tuberosities, specifically nestled between the upper and lower epiphyseal lines. And crucially, they usually don't destroy the bone right up to the articular cartilage. Often they leave a small margin of normal bone visible.
Okay, so there's a little buffer zone.
Exactly. And on X-ray, they present a distinctive, fluffy cotton wool appearance. It's quite different from the characteristic cubeculations, those bony struts you'd see in GCTs elsewhere. You'll often spot a thick buttress of cortical bone just below the tumor, which suggests the condition has likely been present for a long time.
Right, suggesting chronicity.
Precisely.
Yeah.
Clinically, these primarily affect younger patients, typically between, say, 12 and 24 years old, coinciding with when those epiphyseal lines are present. Symptoms often have a relatively long history, averaging over a year perhaps. And here's the really critical point for practice. Early symptoms can strikingly mimic subacromial bursitis.
Ah, that's a pitfall.
It really is. They cause pain and restricted motion, especially in patients under 20, an age group where true subacromial bursitis is actually quite rare. So if you see a young person presenting with what looks like persistent bursitis, you absolutely have to think of this. Historically, these were considered essentially benign. Conservative treatments like curettage, radiotherapy, even excision without amputation were often successful. It reflected the surgeon's clinical judgment favoring limb preservation. There was even considerable historical debate about their classification, partly because of that rather long and descriptive name.
That mimicking of subacromial bursitis in a younger patient is such a crucial takeaway. What a potential diagnostic trap indeed. Now, beyond these fascinating giant cell tumors, what about other benign osteogenic tumors, things like osteomas or chondromas? How do we identify those, and what are the surgical considerations there?
Good point. Moving on to benign osteogenic tumors like osteomas, chondromas, or exostoses. These are generally congenital, often noticed around the time of epiphyseal union, so when growth plates close. They frequently appear sessile, meaning broad-based, around the humeral head. The key distinction is that they are non-invasive. They tend to push aside surrounding tissues rather than destroying or penetrating them.
Yeah,
See?
non-invasive.
Exactly. Now, while generally benign, large sessile tumors can be tricky. They can branch quite extensively through fascial planes and sometimes surround neurovascular structures, making removal challenging. It's vital to stress the importance of thorough excision of the pedicle's base, the stalk, to prevent recurrence. Any remaining cartilaginous fragments can potentially grow independently. And here's a crucial warning, something important for your practice. Historically, some cases, initially looking benign, have been observed to transform into true osteogenic sarcomas.
Really?
Yes, sometimes after repeated ineffective surgical interventions, or even apparently spontaneously. It suggests there might be a sort of borderline category between clearly benign and clearly malignant osteogenic tumors. It means histological assessment alone might not be enough. You absolutely have to consider the full clinical picture, the history, the X-ray findings. Vigilance is always required, even with seemingly benign lesions.
That's a sobering thought, that potential for transformation. It really underscores the need for careful follow-up. This raises another important question then. Beyond primary bone tumors, what other conditions in the shoulder, often benign, can present with a startling appearance that might lead us down the wrong path, making us suspect a neoplasm?
An excellent transition because there are several important mimics.
Right.
One that comes to mind is massive subacromial bursitis, particularly in the context of rheumatoid arthritis, RA.
Okay.
That's a chronic inflammatory disorder, of course. We've seen some really compelling cases. I recall one, a 69-year-old RA patient with a truly massive, firm, non-tender shoulder swelling. It had been there for 6 years.
6 years.
Yes. And it was initially suspected to be a solid tumor, mainly due to its sheer size and the lack of obvious, clear inflammatory signs. So the key clinical message here is, even with huge swelling around the shoulder, especially in the elderly, benign conditions like infection, cysts, or bursitis must always be kept high on your differential diagnosis list.
So don't just jump to tumor because it's big.
Absolutely not. Imaging, particularly MRI, is crucial here to differentiate the fluid-filled bursa. In such cases, you might notice the presence of what's called rice body-like material. These are fibrin deposits, a known feature in chronic RA and bursitis. Surgical exploration and bursectomy can confirm the diagnosis and provide significant relief. We've seen positive 5-year outcomes after that kind of intervention.
Interesting. What else falls into this category of mimics?
Well, then there's lipoma arborescens, LA, of the subacromial bursa. This is a rare benign condition. It's characterized by a diffuse, sort of villous proliferation of the synovium, the lining of the bursa. Essentially, mature fat cells replace the normal subsynovial tissue. While it's most common in the knee, it is reported in the shoulder as well.
And how does that present?
Clinically, it can cause subacromial impingement syndrome, or SIS, which, as you know, is a leading cause of shoulder pain. Now, MRI is really powerful for diagnosing this. It shows a fat-containing lobulated synovial mass. It has that characteristic fat signal intensity on all sequences, and often you'll see a chemical shift artifact. That combination of findings is almost diagnostic for LA.
Right, so MRI really nails it down.
It often does. Histology then confirms the diagnosis by showing mature adipocytes without any atypical lipoblasts, ruling out malignancy. Successful treatment typically involves arthroscopic marginal excision and bursectomy. We've seen this work well, for instance, in a case of a 55-year-old clerical officer presenting with impingement, and also a 74-year-old female patient diagnosed with both LA and synovial chondromatosis. Both had excellent long-term outcomes after surgery.
And you mentioned bone cysts earlier, too. How do they fit into this picture, especially for younger patients?
Yes, briefly, bone cysts. They are another important differential, particularly in the younger group. You often find these in very young patients, typically under 10 years old, and usually in the metaphysis. They commonly present not with a mass, but with a pathological fracture. Historically, they could be mistaken for sarcomas, especially if the imaging wasn't perfect. This just highlights the importance of really clear-cut X-ray images. These often show a central, slightly dilating tumor, but with an abrupt, specific, well-defined outline, which helps distinguish them from more aggressive infiltrative lesions.
Okay, that clarifies the mimics. So let's shift slightly. What does all this mean for how we interpret patient history? We often encounter patients, don't we, who attribute their symptoms to a specific injury, a fall, a knock, something like that. Professor, how should we as medical professionals really interpret patients' history of trauma when we're thinking about these rare but serious bone tumors? It feels like a common point of public misconception.
That's a crucial point, and you're absolutely right. It addresses a deeply ingrained perception, not just among patients, but often in the legal system, too. This idea that trauma causes bone sarcoma.
Yeah.
However, the scientific evidence, when you look at it objectively, presents very strong counterarguments. Just consider the sheer disparity in numbers. Think about the ubiquity of everyday bumps and bruises. Thousands occur per person per lifetime, don't they?
Easily.
Now compare that to the extreme rarity of bone sarcoma. It was once estimated, perhaps crudely, at maybe 1 bone sarcoma per billion person bruise combinations. The numbers just don't support a causal link.
1,000,000,000 to 1, that puts it in perspective.
It does. Furthermore, there's a clear location discrepancy. Think about the bones most frequently traumatize the phalanges of fingers and toes, the middle of the shin bone, perhaps.
Right.
These are rarely affected by sarcoma. Conversely, common sites for sarcoma, like the ends of long bones near nutrient arteries, often shielded by large muscles, aren't typically high trauma areas. It's also worth remembering that metastatic cancers to bone frequently present with a history of trauma as well, yet nobody seriously attributes their cause to the injury itself.
So the thinking is the trauma doesn't actually cause it, but maybe just draws attention to something already there, acts as an alarm bell.
Precisely. That's the most plausible connection. Trauma is highly unlikely to cause sarcoma. Instead, a bump, a knock, might simply draw the patient's attention and subsequently the doctor's attention to a pre-existing, undiagnosed tumor. The patient feels a new ache after an injury, naturally attributes it to that injury, but the underlying tumor was already present, silently growing perhaps. Now, in some very severe cases, could a significant trauma potentially disseminate the disease, perhaps by breaking a fibrous capsule around the tumor?
Theoretically, yes, that could hasten progression. But getting robust evidence for this is still challenging, especially given the rapid progression we often see with most sarcomas anyway. So the bottom line is, the evidence for trauma directly causing bone sarcoma is very, very weak. The burden of proof for such a causal link remains exceptionally high. And it's quite telling that less than half of recorded sarcoma cases even report a significant history of trauma preceding the diagnosis. The key insight for clinicians, I think, is this. A history of trauma should absolutely prompt investigation, but it shouldn't blind you to the underlying pathology. Treat it as a potential symptom or a revealing event, not usually the root cause.
That's a really important clarification. Thank you. So to wrap up this deep dive then, it's become abundantly clear that diagnosing shoulder masses demands a truly nuanced approach. It's about blending that thorough clinical examination with precise imaging and, when necessary, getting that histological confirmation. We've seen just how critical it is to differentiate between malignant bone tumors, each with its unique characteristics, and these benign conditions like Ehrlichia, epiphyseal chondromatous, giant cell tumors, massive bursitis, or lipoma or arborescens, which can so dramatically mimic serious pathology.
Absolutely. And if we connect this to the bigger picture, the ability to discern these subtle differences is paramount. It not only guides appropriate treatment, which is obviously key, but it can also prevent unnecessary anxiety for the patient. And, importantly, it helps avoid potentially overly aggressive interventions that might not be warranted. Our evolving understanding of conditions like those peculiar giant cell tumors of the humerus or the sometimes deceptive presentation of chronic bursitis, well, it just highlights the continuous evolution of orthopedic knowledge, doesn't it? And it underlines the value of critical appraisal, really looking carefully at every single case.
It really does, and this raises an important question for you, our esteemed listener. In your own practice, how often do you find yourself balancing that alarming appearance of a mass with the possibility of a benign, treatable condition? What's your immediate next step when you're presented with a particularly challenging shoulder mass? If you found this deep dive valuable, please do take a moment to rate and share the show. Join us next time for another deep dive into the fascinating world of orthopedics.